Thank you, Dr. Shue, for the nice introduction. Hi, everyone. Thank you for this opportunity to share with you the global epidemiology and risk factors for breast cancer. I hope my screen is visible.
Yes, Doctor, it's visible.
Yeah. I have no disclosures to make. That's the breakdown of my talk. I'm going to look at the incidence of breast cancer globally as well as the mortality. I also focus on the key risk factors for breast cancer and the distribution of some of these risk factors globally. And then I'm going to provide an overview of the GBCI, the Global Breast Cancer Initiative, which will be touched on by the later speakers. Looking at the global distribution of incidence of breast cancer, what we see is, differences in the global burden of breast cancer across the various world regions. Overall, breast cancer is the second leading type of cancer. That's after lung cancer, with approximately 2.3 million cases reported in 2022. What we see on the map on the screen is the differences in how this burden is distributed across the world, with regions of Western Europe, some parts of South America, Australia, and North America showing higher incidence compared with other regions globally. And if we compare that with the breast cancer mortality, then we see the stark differences or the stark disparities, that the regions of the world that have the highest incidence are not necessarily the regions that have the highest mortality. We see higher mortality being reported in regions of Africa, some parts of Eastern Europe, parts of Asia, and also some parts of South America. And again, breast cancer is the fourth leading cause of cancer deaths after lung cancer, colorectal cancer, and liver cancer, with more than 660,000 deaths estimated in 2022. So this difference in incidence and mortality is one of the peculiarities of breast cancer in comparison with other cancer types, that we see regions with the highest incidence are not necessarily the ones that have the highest mortality, meaning that there are some interventions that could be working in some regions of the world that are not fully implemented in other parts of the world. So what do we expect with the breast cancer burden in future? There is a projected approximately 41% increase in breast cancer incidence by 2040, and more than 52% increase in deaths by the same period. Unfortunately, most of these burden of both incidence and mortality will be driven by countries of low and middle income status. And so, there is need for focus on evidence-based interventions that can reduce breast cancer incidence and mortality in these particular regions of the world, if we are to reduce the disparities that we've seen across the world. So breast cancer is a priority health topic, or should be a priority health topic across most countries in the world, because it's actually the leading cancer type for most countries globally. This map shows countries across the world where breast cancer is a leading cancer type. And as you can see, it's basically the entire world, with countries in sub-Saharan Africa, some parts of West Africa, and maybe one or two other countries across the world. Breast cancer is actually the leading cancer type. So this is actually a cancer control topic that the entire world should be speaking in unison on the best way to approach in reducing cancer burden. Touching on risk factors for breast cancer, there are very many risk factors for breast cancer, some modifiable, some non-modifiable. Unfortunately, risk factors for breast cancer cut across the entire lifespan, meaning some aspects of just the usual life experience of women puts them at risk of breast cancer, starting all the way from birth to teenage, to their reproductive life, and even their post-reproductive post-menopausal life. There are many aspects of their biology that predisposes them to breast cancer. However, there are many other risk factors for breast cancer that you can actually do something about. And the whole purpose of principles of epidemiology in public health programs is to identify, the factors that you can be able to modify to reduce disease burden. And so there are some inherent biological risk factors that you can do something about, things that like some germline mutations that can inform our screening strategies, and that can inform some of our primary preventive strategies through use of medications or even some surgical approaches. But by and large, there are many behavioral risk factors for breast cancer that you can be able to use public health programs that cut across the entire population to reduce disease burden. Now, I'm going to just focus on two of these risk factors, and that's alcohol use and obesity. So looking at distribution of alcohol use across the world, again, we see the differences, and this can actually explain some of the differences we see in the disease burden across the world. And as you can see, there are regions that have, some of the highest use of alcohol globally, but also what you're seeing across the world is, traditionally use of alcohol is, associated with, males. We tend to see a higher burden of use among males than females. So to come to alcohol use is narrowing down. So as you can see on the right side of your screen there, that's from the US, but it's many other countries are experiencing the same. We are seeing the levels of use of alcohol, actually differences between the two sexes narrowing. And this may point to a potentially higher disease burden of breast cancer in the coming years. If we look at the next key behavioral and modifiable risk factors of obesity, then we see, unfortunately, there is a rising trend of obesity across most regions of the world. Some regions, we're seeing a higher increase, but basically in between 1980 and 2016 to 2020, we are seeing an increase in the burden of obesity. Something as you see here very quickly, if you compare the previous slide, is that different parts of the world, the disease burden may be explained by different risk factors. A very good example is North Africa and the Middle East, where you see the use of alcohol is much lower in comparison with other regions of the world. But now if you look at the other risk factor of obesity, you can see that those particular regions of the world then have, higher rates of obesity in comparison with, for example, other parts of sub-Saharan Africa or even some other parts of Asia. So this means that public health programs need to focus and see what are the major contributing risk factors to their disease burden so that they target specific strategies to reducing those particular risk factors as per their regions. And then if we do this, then we may see a change in the disparities we're seeing in the incidence of breast cancer across the world. For completeness sake, I'll just mention that breast cancer occurs in men as well. If you're to look at breast cancer control globally in the equity lens, then yes, breast cancer does occur in men. It occurs at a lower rate than in females. So in most countries, it may not be a major public health issue, but again, we need to remember in our programs to include some strategies to reduce disease burden in males as well. One of the advantages is that actually most of the risk factors are actually shared between breast cancer in males and females, both modifiable and unmodifiable. Alcohol use, obesity is also recognized as risk factors for male breast cancer, as are some germline mutations and genetic risk factors. So, interventions across our health programs that are targeting female breast cancer may end up having impacts as well on male breast cancer. So it's good always to keep that in mind, that disease affects males as well, but at a much lower rate than in females. I'm just going to provide the breast cancer initiative and then link it to cancer, but the details will be focused on in the subsequent talks. So what I've just shown you, the disparities in incidence and mortality of breast cancer across the world, is actually the main justification for the launch of the Global Breast Cancer Initiative by the WHO and ratified by countries, or now in the process of being implemented by countries across the world. So it's actually to reduce that breast cancer outcome disparities globally. And the recognition is the fact that the distribution of risk factors seems to be quite uniform in various parts of the world. Then the differences could be in some interventions that are known to reduce breast cancer mortality, especially. And, some of these is what you can see on the screen there, including late diagnosis, inadequate health services, and then, low coverage, especially of financial protection or universal health coverage for breast cancer services. And with all these in mind, then, this informed the structure of the GBCI itself, structured in 3 pillars. If you look at those 3 pillars, they actually aimed to address three key gaps, or three key intervals in the breast cancer care pathway. Pillar one, the first pillar, targeting the first interval, which is health promotion for early detection. So basically, public health education to improve awareness of signs and symptoms to ensure that women are able to seek care early. Diagnosis. So when these women interact with the healthcare system, then the system is able to actually detect breast cancer early and link them promptly to care. And then pillar three, focusing on the third interval, which is ensuring effective treatment, multimodal treatment for breast cancer. And you can also see the three targets for each of these pillars. At least 60% achieving diagnosis of at least 60% of the diagnosis being made at early stages, stage 1 and stage 2. At least diagnosis being achieved within a 2-month period, not more than 60 days, and at least 60% of women with invasive disease receiving multimodal treatment for breast cancer. And all these is meant to move the world towards the targets of, by 2040, of reducing breast cancer mortality by at least 2.5% per year, which is estimated to prevent up to 2.5 million deaths. These initiatives also identify some key enablers that both regional and country teams need to have in mind. First of all, ensuring that all stakeholders are on board, putting stakeholders together, exploring all the various strengths to move towards the achievement of these three key targets. And then having operational guidance, both from institutions like the WHO, up to the regional offices, up to the country level teams, providing operational guidelines on how to move towards implementing the various strategies. And then, of course, having a broad-based in-country engagement to move towards improving breast cancer services in the population. So I'm going to stop there and pass on to the next speaker. Thank you very much for having me.
Thank you very much, Dr. Mwenda, for your very informative presentation. We believe that our webinar participants have learned an excellent overview of breast cancer epidemiology, how huge is the burden across the world, but with the disparities among the countries. And especially, I believe the information of risk factor across the entire lifespan give us the whole picture in just one slide, and it was quite useful. Thank you very much again, Doctor. So for the second agenda item of today, I would like to introduce you with a brief biography of our speaker, Dr. Partha Basu. Dr. Basu is the head of the Early Detection, Prevention and Infection Branch at the International Agency for Research on Cancer for WHO, France. Dr. Basu was graduated in medicine in 1988, and after that, he did his MD in gynecology, postdoctoral training in gynecology, oncology, and PhD in clinical oncology. Before joining IARC in 2015, he was head of the Department of Gynecological Oncology at the National Cancer Institute in India. Dr. Basu is well known for his research that has informed several guidelines and recommendations from WHO and other international organizations. Dr. Basu has 292 publications in peer-reviewed journals with more than 9,000 citations. With many thanks for agreeing to support our webinar, may I cordially invite Dr. Partha Basu for sharing us the health promotion for early detection of breast cancer, which is the pillar 1 of the Global Breast Cancer Initiative. Dear Dr. Basu, the floor is yours.
Thank you so much, Dr. Shrey. Let me share the screen. Hope it is visible now.
Yes, it is visible now. Okay. Now in the presentation mode, Dr. Thank you.
Thank you. Good afternoon, good morning to friends and colleagues. As my friend Valerian just explained to you that there is the Global Breast Cancer Initiative from the World Health Organization. And between myself, Mary, and Anita will be presenting 3 different pillars or strategies through which the countries can achieve this the targets for the Global Breast Cancer Initiative. Before I explain the targets for the initiative, let me focus on this map again that again Valerian has already explained to you. This is a uniqueness of breast cancer. I mean, if we look at the global north, the North American countries, the European countries, they have very high incidence of breast cancer as compared to the global south, the Latin American countries, the sub-Saharan African countries, South Asian countries. But then when it comes to mortality, the mortality is much, much higher in the global south. And essentially, this is because of two reasons. Number one, late diagnosis of the disease. And number two is limited access to diagnostic and treatment facilities. And we have to keep in mind that breast cancer is eminently treatable, especially if it is detected at stage 1 or stage 2. The 5-year survival can exceed 90%. Even then, more than 60% of the deaths, unfortunately, are happening in the low and middle income countries where the breast cancer incidence is still low. So this is a classic example of what is happening in the low and middle income countries. This is a systematic review of the studies that included more than 24,000 breast cancer patients with known stage distribution in Africa. And as you can see, excepting some of the studies that included non-Black population in South Africa, all the studies, they have more than 60% of the breast cancers detected at stage 3 and stage 4. And on an average, it is 77%. So you can well understand the gravity of the situation. And even you can see in the region, there is a huge inequity. Among the South African non-Black population, the stage distribution is like 50-50. Half of them are being detected in early stage. So with that background, if we have to focus on the WHO's Global Breast Cancer Initiative, as Valerian explained, that the aim or the goal of the initiative is to ensure that the global breast cancer mortality reduces by 2.5% per year. And it has to be globally, it has to be for every country. And this is feasible. It is not that it is something aspirational only. There are countries that have been able to achieve, say, for example, 60% of the breast cancers that they're detected at stage 1 or stage 2 at diagnosis. If we can ensure that all the women, they complete their diagnostic evaluation after they come in contact with healthcare facilities within 60 days. And if we can ensure that at least 80% of the breast cancer patients, they undergo multimodality treatment without abandonment, it is feasible to reduce the mortality from breast cancer by 2.5% every year. So strategically, we need to think about three things. First thing is health promotion for early detection. That will be my focus of topic. Secondly, there has to be timely breast diagnosis. And third, comprehensive breast cancer management. Now, for breast cancer, there are certain risk factors, but then not all of them are modifiable. So if we focus on the modifiable risk factors, that where we can think about some interventions, what are those? Number one, we know that every pregnancy gives some protection against breast cancer, but then we cannot ask women to have more children. So that is not really a preventive measure, but what it can be a preventive measure is to encourage breastfeeding. So, breastfeeding offers a significant amount of protection against breast cancer, especially if women can breastfeed for 12 months. But then we should encourage women to at least do 6 months of exclusive breastfeeding. That will give them some protection against breast cancer. Another very important aspect in terms of preventable risk factor for breast cancer is physical activity, avoiding obesity. So physical activity, as you can see, there have been several studies that have shown that physically active women, they have 10 to 20% less risk of breast cancer as compared to those who are not physically active, and especially obesity is associated with postmenopausal, with higher risk of postmenopausal breast cancer. So this is where we can think about some interventions. And again, alcohol intake is associated, it is now recognized as a carcinogen for breast cancer, colorectal cancer. And there is no such thing as an acceptable limit for alcohol. So we need to also kind of propagate this message. Having said that, primary prevention, especially that is associated with behavioral change, is not at all a very easy public health intervention to implement. And especially when it comes to physical activities, promoting physical activities, it is just not a consideration of health sector. It's a multi-sectoral consideration. Say, for example, urban development has to make sure that there is enough space for children to play. There is enough space for elderly or adult people to do physical activities. And especially on the right side, you can see the excellent work that has been done in Colombia to create very nice bicycle tracks in the Bogota city. So physical activity, promotion of physical activity certainly will have an impact not only on breast cancer, it cuts across all the non-communicable diseases and several other cancers, say for example, prostate cancer, colorectal cancer. So that should be, so we need to do something about promoting physical activity, avoiding obesity, avoiding the sugary drinks. Many countries are now adding sugar tax to these cola drinks because they are one of the primary cause of obesity among children. Moving from primary prevention, when it goes into secondary prevention aspect, we talk about early detection. We need to understand early detection has two distinct components. One, all of us know about screening. Screening essentially targets women within a certain age group who are apparently healthy, asymptomatic, do a test on them to identify those who have a probability of having cancer. And then these women, they undergo further evaluation and cancer may be detected in some of them. So here you can understand it's a huge public health exercise because you'll have to focus not only, you'll have to make sure that there is a high coverage of the population and the population undergoes screening. It's just not one-time thing. That is again about with breast cancer natural history. This is the big difference between breast cancer and cervical cancer. Cervical cancer, we know that, if we use a test like HPV detection test, twice in a lifetime, HPV detection test is good enough for those who are negative on the test. But breast cancer screening has to be repeated every 2 years or 3 years. So breast cancer screening, I'll discuss it further. It is a useful initiative, it's useful public health intervention in terms of saving lives from breast cancer. It does achieve significant downstaging of the disease, but then it is very complex to implement, especially in the most low and middle income countries. On the other hand, if we focus on the second approach, which is an early diagnosis of breast cancer, this essentially focuses on the women who present to the health facilities with symptoms of breast cancer. And the focus will be only on these symptomatic women, making sure that these symptomatic women are appropriately examined. And if found to be, if there are any abnormalities detected in breast, they should be put in the diagnostic care pathway. And if cancer is detected, they should be put in the treatment pathway without delay. So early diagnosis is about, number one, improving awareness in the community so that the women present to the health facilities whenever they have any of the symptoms. Number two, which I consider as the most important part of it, is to make sure that the primary healthcare providers are trained enough to be able to recognize the early symptoms of breast cancer and do a good quality breast examination. And number three is making sure that an access is created for these women with suspected breast lesion to undergo diagnosis and care. So this, you can understand, is something doable because we are focusing on a smaller number of patients who have a very high risk of having a cancer, and this should be priority for every country. Now, you have all heard of breast self-examination. So we have to understand something, that even in the US or in the European countries having good quality mammography-based screening, 50% of the breast cancers are detected by the women themselves. They palpate a lump and then they go to a doctor and the breast cancer is detected. So the women's ability to be able to recognize an abnormality is very important. And breast self-examination is educating the women about the concept that they can feel their breast from time to time. It may not be every month, but then they should be feeling it from doing this examiner checkup on a regular basis. And if they find any abnormality, they should report to the primary care facility without any further delay. BSc has also been tried in a screening setting. There has been a big randomized control trial in China where they didn't find that BSc was reducing mortality. But then we have to think about in the China, the health system, especially in the study, was that all the women, they had access to good quality care. So the comparator arm also had good quality care. So there are many issues with that. But then having said that, BSc is not recommended as a screening test, but for educating women to be able to recognize any abnormality in their breast is part of what we call breast awareness in the community. And this is again something to be promoted, and it will definitely have an impact on early diagnosis of breast cancer, as has been shown in this region. Only in Malaysia, there was a study that has shown the impact of breast awareness. Now, I'll present an interesting data from one of our large randomized control trial that looked at clinical breast examination as a screening test. As you know, clinical breast examination is systematic examination of the breast and the armpit or the axilla, where there are two components, the inspection component, then there are palpation component. So the clinical breast examination is something that people have been looking at as a screening test, especially in low and middle income countries where we know the mammography-based screening is almost impossible to implement. So in this randomized control trial that we implemented in southern part of India, you can see there are a large number of women who are recruited. In one arm, women underwent CBE every 3 years for 3 rounds, and in the that was the intervention group. And in the other group, which is the control group, we didn't do any screening. And in India, there is very little access to mammography screening. But we told all these women about breast self-examination. We created an awareness of the breast awareness, and also we made sure that these women also have access to good quality diagnostic care and treatment care. So when we follow up these women over 15 years nearly, you can see the left graph, you can see there is no difference in the incidence of advanced stage disease. So normally we expect that if a screening test works, there will be the advanced stage disease incidence will come down in the screening arm as compared to the control arm. It didn't happen in our study. Same thing happened with the breast cancer mortality. 15 years after we started the study, there was no difference between the arms. So essentially, this again proves the power of breast awareness linked with good quality access. So even if we don't, we are not being able to implement a good quality, high coverage CBE-based screening, if we focus on early diagnosis, there will be an impact in terms of saving lives of the women. So this is what is our early diagnosis is all about, reducing the delay in the pathway of care. So the delays, we now divide them into access delay or pre-diagnostic delay. That means the interval between a woman recognizing the symptom first and the woman going to a health facility for the first time. Second one is the diagnostic delay. That is the gap between the health facility, seeing the woman and the woman getting a diagnostic confirmation, and the treatment delay is the next part, which is between the diagnosis and initiation of treatment. There are certainly some reasons which we call patient-related or woman-related issues. There are demographic factors. For example, elderly women generally have less awareness. They don't want to go to a health facility. Socioeconomic factors, financial constraints, lack of family support, lack of empowerment, again, can be a big hindrance for the women to go to the health facilities, to get the diagnostic care, getting the treatment care, health beliefs. So all these things are there. But then most of the time, whenever we discuss about the early diagnosis or the delays, we always put the blame on the women. To me, it is not the women, it is the system that we need to think about. So we need to think about the health system and how the health system can create those barriers and how we can avoid these health system barriers. Say, for example, in the service delivery, if the quality of the service is poor, if there is a long waiting time, these women who have some symptoms which still they are not thinking about cancer, they are not going to wait there. Or if another issue is with the workforce. With the primary healthcare providers, they do not have the adequate index of suspicion that a woman coming with, complaining of a small lump in the breast or complaining of nipple discharge, which is bloody, should be examined properly. And that can be a big hindrance. So, and then also lack of female staff in the primary care can be a barrier in many cultures. So we need to think about that. We need to think about the financial constraints. In some of the settings, the examination in the primary care is free. But when the woman goes into the diagnostic care pathway, treatment pathway, they have to pay. So that can act as a barrier. And access to technology, certainly, we know mammography is a very important part of diagnostic care. It may not be used in a screening setting, but for diagnosis, mammography, ultrasound, core biopsy, these are essential technologies, and these technologies need to be there for the diagnostic care. Coming back to the screening, mammography screening, yes, as I said before, we are at IARC, we have done a review of all the studies, and our take is that 50 to 69 years or 50 to 74 years of age, if women undergo systematic mammography screening every 2 to 3 years, there is significant reduction, 20 to 40% reduction in in breast cancer deaths. But then, considering the fact that implementation of mammography screening, even in some of the emerging economies like Brazil, they're struggling. They have set up a lot of machines, but then ultimately those machines are not being able to provide the appropriate service. So we need to think about alternatives. As an alternative, clinical breast examination, even as far as I know, Myanmar has CBE-based screening in their screening policy. CBE screening is being practiced in many countries because our randomized control trial and another trial in Mumbai, they have shown even though there is no mortality reduction, but then it does achieve downstaging, it improves survival. So many countries have gone for CBE-based screening. But then again, I will kind of impress upon the fact that CBE is an important component of the diagnostic care. This picture you are seeing, this woman, she went to two health facilities, one to a primary care, one to a gynecologist, with the complaint that she was feeling heaviness in the breast. Nobody decided to, went for a breast examination. And then when she presented at stage 3. So clinical breast examination is an important part of the diagnostic care, and it is part of what we call triple diagnosis. So any woman who presents with symptom should be examined clinically, and if there is any abnormality found, she should go for diagnosis, radiology. Radiology can be mammography, that's very accurate, but for our kind of setting where women present with large lump, as you can see here, the ultrasound is very good in terms of picking up the disease and the characterizing the disease. And then we have to go for core biopsy that can be ultrasound guided or it may not be ultrasound guided. But this is essential part of the early diagnosis component, which also in the screening component, ultimately women will come for triple diagnosis. So to conclude, that primary prevention, yes, there are opportunities for primary prevention, but then the impact is likely to be low. So we need to think about early detection and especially focus on the system level barriers that prevent women to get timely diagnosis and good quality treatment. Inequities in care has to be tackled, and one has to look into specifically, because yes, the women in the urban region, women who can pay for different services, they will get the facility of mammography screening, they will get a facility of mammography as a diagnostic test. But we need to think about the women who are in the hard to reach areas and who have poor capacity to pay. So many of the countries are now coming up with interesting financial model, including use of insurance. So we need to think about that. And we need to keep in mind that saving a woman from breast cancer is just not saving the woman, it is saving the family. Because one of our colleagues has very nicely shown that for every 100 breast cancer deaths, there are 100 orphans, of whom 14 will die before they reach the age of 10 years. So thank you so much. I'll be happy to take questions.
Thank you very much, Dr. Basu, for sharing the very useful and practical information. We'll take all the questions from the Q&A box at the end of the awful presentation, Doctor. Thank you very much. We hope that from your presentation, our webinar attendees are now more aware of the importance of early detection of breast cancer and its implications. And at the same time, we need to consider how to address these health system barriers for breast cancer diagnosis. Thank you so much again, Dr. Basu, for highlighting these. For the next agenda item, may I introduce you with a brief biography of our third speaker, Dr. Mary Nyangasi. Dr. Mary Nyangasi joined WHO in 2024 January as the technical lead for the Global Breast Cancer Initiative at WHO headquarters, Geneva. Dr. Nyangasi is currently focused on implementation of the GBCI and the integration of women's cancers into national cancer control planning in member states. She is a medical doctor, health assistant, and public health specialist in cancer epidemiology and disease control with extensive experience spanning 13 years in various aspects of oncology. As the immediate former head of the National Cancer Control Program in Kenya, Dr. Mary led the establishment and operationalization of regional cancer centers, scale-up of cervical and breast cancer screening and early diagnosis, formulation and implementation of various cancer policies, strategies, and guidelines. She has published in various peer-reviewed journals. So with heartfelt thanks for agreeing to support us for today's webinar, I would like to invite Dr. Mary Nyangasi to kindly share us the background and overview of the Global Breast Cancer Initiative with a focus on Pillar 2, timely diagnosis. Dear Doctor, the floor is yours.
Thank you so much, Shwe and colleagues from WHO Country Office, Myanmar, for inviting me to speak about the Global Breast Cancer Initiative, and especially with a focus on timely diagnosis, which is the Pillar 2 of the Global Breast Cancer Initiative. So I hope you can see my screen.
Yes, Doctor, we can see it.
So I will just show you the outline of my presentation, which basically I'll give you an outline of the GBCI, especially on Pillar 2. And then I'll focus on the breast cancer timely diagnosis and what we are doing generally in accelerating implementation of the GBCI in this regard. So I'm just wanted to show this slide to give you background of why we are implementing the GBCI, and just also to also allude to what our previous speakers have already spoken about, including Dr. Valerian, who already shared with us that 95% of countries globally actually have breast cancer as either the leading or second leading type of cancer deaths, cause of cancer deaths in their countries. And we have 85% of countries with breast cancer as the leading type of cancer. And this is from Dr. Mwenda's presentation. And this actually leads us to why we really need to have breast cancer on the global agenda. Of course, we have seen the survival differences spanning as much as 60% between the high-income countries, where we see survival rates of nearly 90%, as compared to average survival rates of about 30% in most low and middle-income countries. Such a stark difference that really means that we need to do something. Again, when we look at mortalities, most of them, 70%, are occurring in the low and middle-income countries, despite the low incidence rates. And we have seen that globally, only about 11% of countries, all of which are in the high-income countries, have achieved what we could call quality organized mammography screening programs. So this is something that's aspirational for most countries, but as you've heard from Partha's presentation, there's something we can do. We need to focus on early diagnosis, and in fact, the guidance we have at WHO is that before you move to a screening program, you must have implemented an early diagnosis program, which allows the system to build capacity for screening. It's not possible to start with a screening program entirely. Even when you look at the principles of screening, you really need to make sure that the benefits outweigh the harm. And that means that you have to build your capacity for diagnosis and treatment before you move into screening. So early diagnosis actually enables you to do this even as you're preparing eventually to move to screening. So I think I just wanted to highlight the high survival rates. It's just to show you what Dr. Mwenda presented about countries with high survival rates. What we've observed is that these countries are actually characterized by increased coverage of essential services and strong health systems, where a majority of services are provided within the public universal health coverage system in the public cancer center. So issues of access is really what has made a difference in the high-income countries where survival rates are better, and health system barriers in access have been basically almost eliminated, but not really entirely, again, because still in these countries we see pockets of populations that are still having challenges in access. So just to share something about data, we cannot speak about breast cancer without sharing information about data. It's a challenge, as you can see from the map here. When we look even at the survival rates from breast cancer, you can see the countries where there is no data, where we highlighted earlier that we have high burden, but there is no data to even assess. Registries are a challenge. So we need also to look into how we can generate data so that we can properly monitor our programs for breast cancer. So I just also wanted to highlight that breast cancer is one of the NCD best buys adopted by member states during the World Health Assembly of 2023. So it's one of the expanded best buys for national policies for implementation. So breast cancer screening, timely diagnosis, and comprehensive treatment are actually encouraged for implementation by member states. At the WHO, we've also been looking at what is feasible, and the concept of integration of service delivery has been gaining quite momentum, especially in low and middle income countries where we might have challenges in terms of resource for human resource and even service delivery points and building more infrastructure. So we are looking at how do we deliver care for breast cancer in an integrated service delivery model so that we can achieve public health, primary care. We can have breast cancer integrated within the primary care, provided maybe even in the sexual and reproductive health clinics, in the HIV clinics, reproductive health clinics, maternal health clinics, so that it is patient-focused rather than vertical programs. So again, when you look at the justification here, for example, we can see CVD and breast cancer, because of the shared risk factors, there are areas where there's a lot of overlap. So it only makes sense to provide care in a way that is patient-centered and which reduces, delays in terms of accessing these critical services in a timely manner. So I'll move quickly to timely diagnosis, just to give you a brief background. I think I won't speak so much about this, but just to mention that in terms of methods for breast cancer screening, we have mammography as what is actually the gold standard method for screening. However, we've established from randomized controlled trials done in India by Dr. Partha. So honored to have you here on this panel, that clinical breast examination actually can achieve downstaging, and there is sufficient evidence for that. And so this moves us to support and encourage countries to adopt early diagnosis of breast cancer as a strategy that can be implemented even within primary care. Clinical breast exams can be done in any healthcare facilities, really, and we need to train our health workers in this regard so that they are able to do it competently. So just to share with you, the situation in most countries is that there is lack of treatment facilities. So this is just to highlight why we cannot start with screening. If your situation is you don't have capacity to treat, then it does not make sense for you to start with screening. You need to build that capacity for diagnosis and treatment concurrently before you can move to entirely a screening, population-based screening program. So we need to look at, sorry, I'm talking about mammography screening. So we need to strategically start with early diagnosis using clinical breast exams before we moved to the mammography-based screening program in the long term, when the system is ready and we've assessed ourselves and found that we are now at that point. I also wanted to quote a quote that I like from the Women Power and Cancer Lancet Commission, that of the 2.3 million women who die prematurely from breast cancer every year, about 1.5 million could be averted through primary prevention and early detection strategies, and 800,000 could be avoided if all the women could access optimal cancer care. So again, this just means that we can avoid all premature deaths if we do something about it. Going just to pillar 2, this is around a definitive diagnosis. The second pillar of the GBCI is around how do we ensure that women who are found to have symptomatic lesions or suspected breast cancer can have diagnosis within 60 days of presentation. And this is actually evidence-based. Beyond 60 days, chances of survival start to drop significantly. So there's need to ensure that women who are found to have suspected breast cancer or lumps on clinical breast exams are quickly get a triple assessment, which encompasses a clinical evaluation. So again, another CBE, probably at a secondary level care facility by an expert, followed by imaging, usually mostly ultrasounds, because especially in the settings where we have large masses, ultrasounds can do well for the lumps that we find, but also combined with diagnostic mammography. We cannot ignore the fact that mammography will still be useful even in the CBE screening in terms of diagnosis. So again, just to encourage Myanmar and other countries to focus also on building capacity for mammography, even for the clinical breast exam kind of screening. And then after that, there'll be tissue sampling, core biopsy, which can be ultrasound guided or non-ultrasound guided, and in some settings, even fine needle aspiration, and then pathology. This pathology diagnosis is actually the entry point for cancer care. Without a pathological diagnosis, it's not possible to begin cancer care. And so getting the pathology report within 60 days is critical in this pillar 2, so that we can achieve timely diagnosis for breast cancer. And WHO has actually done quite a bit in this regard. we have developed a guidance for pathology, establishing pathology laboratories and in our facilities. And just to reiterate that pathology, apart from the fact that it's useful during diagnosis of cancer and as an entry point to cancer care, it's also useful during treatment. When maybe you do your surgery, again, you will need to send that sample for pathological assessment. And during treatment, there is also the value in checking response to treatment through pathological evaluation. So it's actually useful beyond the diagnostic space. So in implementing 60 days diagnosis, there is need to make sure that we build capacity of the health worker to be able to do clinical breast evaluation and facilitate imaging of lumps found on the clinical breast evaluation, either through ultrasound, diagnostic mammography, and also access to biopsy and histopathology services. So we are actually encouraging that we're able to assess the histological type and grade. And after the confirmation of a breast cancer diagnosis, again, you'll find because we have many molecular subtypes of breast cancer, we will need also to conduct immunohistochemistry to determine which molecular subtype we are dealing with, because again, that will influence the treatment that is provided as we move to personalized care. So this slide I just pulled from ESMO guidelines that were released last year, 2023, on just to share, for example, what happens clinically during the diagnosis and staging of breast cancer. Bilateral mammogram and ultrasound of both breasts and regional lymph nodes, and sometimes MRI for special situations, especially those with high risk in the high risk populations. And then you have co-biopsy. Once the diagnosis is confirmed, then you assess for biomarkers, as I mentioned, through immunohistochemistry. You might have to do ER/PR/HER2, Ki-67 to know which subtype we are dealing with. And then from there, we are able to stage the disease and final pathological assessment according to WHO and UIC CTNM staging, and be able to do workup, medical laboratory workup, of course, to make sure that we, the body, function, liver function, and so forth are good enough for systemic, surgical, or radiotherapy treatment. And sometimes in the process of staging, we might need to do CT scans, MRIs, and so forth, and plan appropriately for care. So some of the resources I want to share in this webinar that we have available are guidelines for establishing a pathology laboratory. We have seen challenges in this regard in many, especially in the low and middle income countries. And yet, as I have said earlier, diagnosis is the entry point to cancer care. So we need to really build capacity for pathology laboratories in the context of cancer control. And this guide is publicly available. We also have several other guidelines I have listed here on my screen, which we can look into, including the list of priority medical devices for cancer management, which highlights some of the devices relevant to breast cancer, such as the biopsy needles and biopsy guns that are used for tissue sampling. So if we look into this document, we might find more information, including also what the ultrasounds and mammography. We also have a documentation on the specifications of this equipment. If you require them, we can provide guidance to you. So in implementing the Global Breast Cancer Initiative, we are basically looking at three modalities: convening, providing norms and standards, and country support. And that is why this webinar is very important for us. So convening, discussing about breast cancer, so that we can harness political goodwill. Because breast cancer is a political, it can only happen in countries if we get political buy-in, because we need to build the health system to be able to provide this capacity. So facilitating policy dialogues, advocacy, knowledge sharing, and adoption by regional and countries is really important to us. And then the second aspect is norms and standards. So we've been able to launch this October our first technical product, which is on breast cancer patient navigation for timely diagnosis, screening, diagnosis, and treatment based on evidence that patient navigation works. So we did a systematic review and found that there's enough evidence to implement patient navigation. And we are delighted that we are able to launch this document to be used by member states to advance breast cancer control in their countries. We are working on several other packages and technical products, such as the Global Breast Cancer Initiative Training Manual, integration of breast and cervical cancer programs, and integration of breast cancer in other programs, as well as evaluation and workup of suspected breast cancer. So we are keen to drive in-country implementation through organizing webinars like this and providing technical assistance and support to develop guidelines for breast cancer as and when required, and even investment cases on why countries will need to specifically invest in breast cancer within their contexts. So this is just for the patient navigation. I won't spend so much time on it, but just to highlight that there's strong evidence that patient navigation improves rates of cancer screening, reduces time to diagnosis, reduces hospital readmissions, increases really overall quality of life. And there's also some evidence that it reduces time from diagnosis to initiation of primary treatment. So it should be considered even in the timely diagnosis. And of course, all the three pillars of the GBCI. Thank you so much for listening to me, and I'm happy to take questions at the end of the webinar. Thank you.
Thank you so much, Dr. Mary, for your very insightful presentation. I'm sure all our participants now have become more aware of this global initiative, the three pillars with the respective targets, which we all need to work hard to achieve by 2040. Thank you very much, Dr. So for the last part of today's presentation, may I introduce you with a brief biography of our speaker, Dr. Anita Gadgil. Dr. Gadgil is a surgeon by training and has been professor and head of surgery unit at the Bhakbar Atomic Research Center Hospital, HPNI University, Mumbai, and headed the WHO Collaborating Center for Research in Surgical Care Delivery there. She has public health research experience of over 12 years. She has been part of the WHO Global Breast Cancer Initiative and Cancer Control Program reviews conducted by WHO in various low and middle income countries. Dr. Gadgil has worked closely with the government of Bangladesh as a technical expert in setting up breast cancer screening program and has been part of the technical advisory group at the Ministry of Health and Family Welfare, India. She has been working in preventive oncology in urban community in Mumbai and now in rural and tribal community in Assam. So with huge thanks for agreeing to support us for today's webinar, I would like to invite Dr. Anita Gadgil to kindly share us the management, follow-up, and rehabilitation of breast cancer, which is the pillar 3 of the Global Breast Cancer Initiative. Dear Doctor, the floor is yours now.
You, Sri, and thank you, WHO Myanmar Country Office at WHO Headquarters and PAYAC for this opportunity. And I'm very honored to be here. We have now gone through the epidemiology and the early detection and the diagnosis and the GBCI initiatives in both these pillars. So I would like to share my presentation now on what is the next point in the patient's life, that is the treatment once the diagnosis is confirmed. So this is on behalf of as a part of working group of Global Breast Cancer Initiative. Just a small disclaimer: there's a festival in India going on, so you might have some background noise from my side because of the firecrackers. Thank you kindly. Thanks for your patience with that. So the layout of my presentation in next 15 minutes, we will go through multidisciplinary breast cancer management, which will include surgery, chemotherapy, and radiotherapy. Next will be completion of treatment. What is called completion and how does that affect, and follow-up, and how do you follow up these patients and return them to community for continued support, because breast cancer management will be complete right from the diagnosis, right from the where patient starts from the community till the end where patient returns to the community. That is the whole journey of breast cancer patients. I will cover the treatment part of it. So, as you have known by now, the pillar 1 and pillar 2 of health promotion and timely diagnostic has been covered by Dr. Partha Basu, Valerian, and Mary. I will focus on pillar 3, which is comprehensive breast cancer management. And the goal of this pillar is that 80%, more than 80% of the patients undergo multimodality treatment without abandonment, and without that is leaving it half. So this is a diagram that you are by now aware and familiar with from the first 2 presentations. So this is the third pillar that I'm going to talk about. As the diagnosis is established, patient undergoes various modalities like surgery, then adjuvant chemotherapy, and then chemotherapy. And if it is metastatic, non-curable, then patient goes into supportive care. So we will go through this one by one. So mainstay of treatment for all breast cancer patients is treatment is surgery. Surgery can be of 2 parts, 2 ways of operating the tumor. One is removal of the entire breast, as you can see on the left-hand side of the screen, where the entire breast is removed. And the result of it is, you are seeing in the lower picture, that the whole breast is removed. As the surgical health system progresses, as the surgical system becomes stronger, we move from entire breast removal to only a small part of breast removal which is affected, which means breast conservation surgery. It includes just a removal of the lump, but both the treatments include removal of the axillary nodes. That means part of the nodes which are sitting in the armpit. Whether it is mastectomy or lumpectomy, the nodes in the axilla have to be cleared. So that is the next part of the treatment. It's the next part of the operation that patient has to undergo. And as we move from modified radical mastectomy, removal of the entire breast, to removal of part of the breast, the morbidity, the side effects, return to life side effects get less, and return to life gets faster, and quality of life improves. So whenever available, Mary talked about sonography, and Dr. Partha also spoke about sonography. So it is very good idea to get sonography of the axilla or the armpit done, so that you know whether there are any nodes available. Everybody has axillary nodes, but whether they are infiltrated by cancer. That means cancer has reached this first station of axillary nodes. This is the first station where the cancer reaches. If it is reached there, there's a likelihood that it has gone beyond, and then you need to step up your treatment. So if there are no other facilities, then you remove the breast, basic facility, you have remove the breast and remove the nodes in the axilla. But if there are further facilities, then you do an ultrasound of the breast, of the axilla, and see if you find some small lymph nodes. Then you can take a sample from there and see if they are infected or if they are infiltrated by cancer. If no, then you can still get away by removing very few nodes for sampling. You inject a blue dye or a blue liquid to highlight those nodes which are infiltrated by cancer and likely to be infiltrated, and you pick up those nodes for biopsy. So if those are negative, then the rest of the axilla, the armpit nodes, you can leave it alone. That means the lymphedema or the swelling of the arm after surgery will be less. If you have even better system, then you can use a gamma camera to actually pick up the radioisotope that you inject into the tumor and see if that has gone. So combining these two ways, you can really pick up whether this cancer cells have reached their first station or the axillary nodes. So that is the purpose of this axillary staging and axillary node removal, which is a part and parcel of any breast cancer surgery, irrespective of whether you remove the whole breast or a smaller part of the breast. So most of the treatment is, of course, like all other cancer treatments, it is tailored as per the stage of the disease. So up to stage 3A, I will not go into the detail, it's a busy slide, but up to stage 3A, you can straight away operate on breast cancer and then give further adjuvant therapy. But if it has gone beyond that, which is a very common scenario in India and as well as in Myanmar, I'm sure, and in Bangladesh and many other low and middle income countries, the tumors are big, 5 centimeters, 6, 7, 8 centimeters, skin is ulcerated. This is not a new scenario to you all and to me in India. Then we have to give chemotherapy, reduce the tumor, make it to a size where you can operate them and then give further chemotherapy and systemic therapy, which we will discuss later. Similarly, stage 4 is metastasis, the intent of treatment. That means the reason for treatment is only symptom control and control of the disease. It is not curable. So that is the scheme of treatment in various stages. Now, scheme of treatment in various settings. That means wherever your whatever are your resources, based on that you can tailor the treatment. If you have basic resources, then modified radical mastectomy is good, because then the radiation that is required after lumpectomy, which is mandatory after radiation, after lumpectomy, if that is not available, then better do a safe and good modified radical mastectomy and leave it at that with axillary dissection. If you have little more resources, then conservation surgery can be done with sentinel lymph node biopsy with just a blue dye. And as I said, if they're enhanced or good facilities, then you can go ahead with radionuclear tracker and then conservative breast surgery. Similarly, as I mentioned, if it's a locally advanced disease, you will need to do a modified radical mastectomy for these patients. Moving on. This moving from basic to enhanced resources, it reduces morbidity or reduces arm edema if you go from basic surgery to enhanced surgery with small surgery of lumpectomy and just sentinel lymph node biopsy rather than huge radical mastectomy. So strategies for improving outcomes of surgery, this is actually applicable for all modalities, whether it is chemotherapy, whether it is radiotherapy, the strategies will remain the same. I will just enumerate it once for surgery, but I just want to highlight that this is applicable to all treatment modalities, that you train the workforce and retain them. The most important problem in low and middle income countries is when a person is very highly trained, he's likely to migrate to higher income countries for remuneration, better monetary gains. So how to retain these people is a very real problem in low and middle income countries. So retain trained manpower or trained workforce. Second is equipment and supply chain. This becomes very important in radiotherapy, which we will discuss a little later. But the instruments have to be available. They have to be maintained well. They have to be looked after. If there's a breakdown, get them back quickly. The downtime, what we call when the equipment is shut down, that has to be minimized. And whenever surgical instruments are available, they have to be sterilized well to have a good quality surgery. Similarly, supportive surgeons, training surgeons and anesthetists is not going to be enough, because you need, as Mary said, you need pathology, frozen section for sentinel lymph node biopsy, you need blood availability, you need imaging, so on and so forth. So it's a multidisciplinary planning and execution. And once you have planned and executed, we need to do a quality control of whether it is, we are giving surgery, radiotherapy, and chemotherapy, but is it timely? Are we giving it in the 2 months interval that is mentioned or that is recommended? Is it good quality surgery and radiotherapy? Is some of the breast getting left behind? Is it a good mastectomy? What are the complication rates? All these questions come into play in a multidisciplinary planning and quality control metrics, what we call it, or key performance indicators. Moving on to radiotherapy. Radiotherapy is required to control disease in the breast following breast conservation surgery, and it may be required to treat the axillary lymph node bed when the nodal disease is extensive prior to surgery. Similarly, large high-grade node-positive tumors after mastectomy also will require radiotherapy. It reduces the local recurrence rate by half, especially in high-risk women. But there is a problem. Radiotherapy is not easily available in each country because the establishing radiotherapy costs are immensely high. Maintaining the equipment is even high. Getting the radioisotope is very difficult. So these services are very severely limited globally due to deficiencies in required infrastructure and trained personnel. So when the radiotherapy is to be given, it has to be given timely, it has to be given without interruption, and it needs to be completed. Patients get depleted of their resources, money, they're losing work if you have a 30-day long radiotherapy sessions and people drop out. So then the radiotherapy is obviously ineffective. So features of successful radiation oncology program, I'm not going to go into the details of it, but it needs to have, not just having facility is not enough. We need to maintain it. We need to have safety, radiation facility. Safety has to be of highest standards because it can be damaging to the patients who are going up and down in that area for different reasons in the hospital, and so on and so forth. It has to be safe. It has to be safe for the patient. It has to be safe for the handlers, and it has to be safe for the environment. So that is why many a times there's regional collaboration for training, quality control, and supply chain. For example, many countries collaborate with India, and some of them even they collaborate with Thailand, whichever some of the countries that I visited, like some of them collaborate with Thailand for backup of technicians when when the machines are down, or support services. So regional collaboration is extremely important for continuing these services successfully. Coming to third modality of treatment, systemic therapy. This choice of systemic therapy for breast cancer is based on how advanced the tumor is, what is the stage, whether the tumor is hormone receptor positive, whether the tumor is HER2 new, that is, whether it can be given a targeted therapy if the HER2 new receptor is positive, so on and so forth. So these are some of the some of the considerations when we decide about systemic therapy. Systemic therapy can be applied at various periods in the breast cancer management or journey. First picture is not new to you guys, nor is it to me, because in most of the LMICs, this is the stage and presentation, which is large, advanced tumors, fungating masses, and so on and so forth. In those, you can give neoadjuvant therapy, reduce the tumor size as we discussed, and make surgical treatment possible. Secondly, post-operatively, as an adjuvant therapy, when you do a breast conservation or a high disease burden in mastectomy. Third is when the disease has spread, metastatic disease, it reduces, the systemic therapy is the mainstay of treatment there to reduce disease-related symptoms and downstage the tumor at that point. So systemic therapy, as you can see, it can be cytotoxic therapy, or what we call chemotherapy is the only cytotoxic part of that portion is called chemotherapy with alkaline agents, antimetabolites, and I don't go into the details of it, it's on the slide. Second could be hormone therapy, which is if the tumor is estrogen or progesterone receptor positive, then you can give tamoxifen, you can give aromatase inhibitors, you can give fulvestrant, and so on and so forth. But which one to give, when to give, you need an expert, and not just an expert in chemotherapy, in systemic therapy. You need a multidisciplinary treatment, because these treatments are multidisciplinary team, because these systemic therapy is quite toxic. So we don't want our treatment to be make the patient worse than what she was, because they will have severe side effects. So when to stop, when to give, which one to give, when to reduce dosage, so on and so forth. A lot of multidisciplinary discussions are required in this. Second is targeted therapy, which blocks epidermal growth factor, for example, trastuzumab. So these are the three main components of systemic therapy, but a very well coordinated multidisciplinary team is the key to success in all these three. Secondly, not just multidisciplinary team, but a cancer management guidelines are important. Guidelines are important because otherwise everything is written in the books. But how do you decide what to give? Because that depends not just on patient condition, but what is available, what is affordable, what is available in the country, what is available in the vicinity. So these guidelines, what we call is resource stratified guidelines. Breast Health Global Initiative. And before that, it was before in its previous versions, and now what we are doing as products, which Mary mentioned or referred to, these resource stratified guidelines have to be followed. Because what is happening in North America, what guidelines they are following, I cannot follow it in northeast parts of India, or you cannot follow it in Myanmar, because those resources are not available. So a context-specific guidelines are very important for adherence, because whatever I say, if you don't have the treatment facility, we will not be able to give the treatment and complete it. So rather, we should choose from what is available. This is just a case scenario to give the treatment aspect a comprehensive overview of it. In limited resource setting, this is a very common case. As you said, this can be given. This tumor will first need a neoadjuvant chemotherapy, downstage the tumor, followed by mastectomy and axillary dissection, and then radiotherapy. So multidisciplinary team with clear communication. I know I'm repeating it, but this point, it can never be overemphasized. It's worth repeating that multidisciplinary team with clear communication is the key to success. And training workforce for a complete and systematic mastectomy can save many lives. I just read in some question in the question box that whether we need training for breast conservation therapy, oncoplasty. Of course, that is very important to reduce morbidity, but equally important is to perform a good quality mastectomy, and that can save many lives within the given resources. Coming to metastatic breast cancer, I'm aware of the time, but I'll keep it short. Metastatic breast cancer is fundamentally, it is to ensure equitable healthcare and avoiding stigma, because these patients, when they have metastatic breast cancer, they are deprived of the care. When you have limited resources, the resources go to curable cancers. The metastatic cancers get left out. They're sent home saying, we do not have any treatment. That's not what is required, but they also need good symptom control. Supportive oncology, or also including palliative care and psychological support, are fundamental, which can be to take care of the physical symptoms, which can be to take care of, as you say, common concerns, stress, depression, anxiety, fear of recurrence, relationships, quality of life, intimacy, and their coping. Or professional support is required by physicians, nurses, social service persons, patient navigators, and so on and so forth. Also, social support is required for these patients because they are isolated and they have a tab. So this is what is required for a systematic approach to a multidisciplinary approach to metastatic breast cancer treatment. And as Mary mentioned, there is a patient navigation material or resource or product coming out from WHO GBCI, So the patient navigator is the bridge which joins the community and the hospital, and then hospital back to the community. So patient navigator is of utmost importance in this entire setup, especially when the patients are illiterate, when they cannot read and write English, when then they are get lost when they go to tertiary care. So these patient navigators are extremely important. Again, when we started, I'm bringing ending with that. The goal, as we mentioned, was without abandonment and successful return to community. So once your treatment is completed, we have to make sure we follow these patients up. Firstly, help them complete the treatment, then follow them up, and then return them successfully to community by occupational therapists, physiotherapists, make sure they are able to do their daily chores and so on and so forth. So their quality of life and their position in the family, as a caregiver in the family and in the society is not disrupted. The role disruption is disrupts the whole family, as Dr. Partha said. One woman, and if she dies, child becomes orphan, the whole family becomes disrupted. So this is our role, to not only preserve her life, but send her successfully back to the community. So that is the pillar 3 that we were talking about. The treatment completion is about when all components of the treatment are completed, and goal is 80% should be completing the treatment. Abandonment refers to failure to complete when there is no medical reason to discontinue. So we need to prevent these. And how do you do rehabilitation and follow-up and return to community? By, as I mentioned, again, a multidisciplinary approach by a dietitian, general practitioner who will follow the patient up, social worker who will make sure that she's not discriminated against, her job is not taken away. They counsel the woman to continue to do the job, not lose wages as far as possible, physiotherapist, and so on, and on the psychological and social well-being, of course. So that's how we can send the women back to community to performing their roles where they started with. So take-home messages is local treatment, trends are towards less morbid procedures, individualized treatments, systemic treatments are based on tumor characteristics and receptor status. Diagnostic to treatment interval should be less than 3 months. Compliance and follow-up of the patient will give survival benefit, and cost considerations to tailor the treatment to cost considerations. And patient's journey from community back to the community after treatment needs to be considered while creating cancer control programs. It means rehabilitation should be an integral part of it. Thank you. And I would love to take questions if we have.